Okay, great. Suman, here we have another exciting champion who really been on the barricade in the front years of newborn care and the state of art. She's a professor of neonatology at St. John's Medical College. She has been a huge voice mentor for quality of care in NICUs. She has been helping assisting WHO, work with WHO on guidelines, and she's also been engaged in innovations, low-cost innovations in this field. So, Professor Rao, we are very excited that you are joining us virtually. We had hoped to see you here, but happy that you can be with us today. So over to you.
Thank you very much for your kind introduction, and I hope I am visible and audible, and you can see my slides too.
Yes.
Thank you. So I think it is very good that I'm coming after Silke. Silke has told us the need, and what I am going to be presenting is the evidence which we hope will guide, push, and ensure that zero separation happens. And this study is not only WHO study. We have the entire KI and Agnes, Bjorn, Nils have all been part of it, and I'm only presenting this on everybody's behalf. So what I'll be taking you now for the next maybe 25 minutes is about the immediate KMC study, and also give a little brief on what WHO is doing to ensure that this is implemented. The WHO has been working in this field of prematurity because it's a huge burden, not only in terms of lives lost, despite contributing to only 15% of all births. The premature and low birth weight babies contribute to 70 to 80% of all neonatal deaths. In addition, they're at great risk for early growth retardation and developmental delay. And we have a tool that is going to address all this, and that is Kangaroo Mother Care. So since 2004, Kangaroo Mother Care has been a recommendation, and at that point it was recommended for stable babies with a birth weight of 2,000 grams or less, and it was recommended to do it as continuous as possible after the baby was stabilized. But in reality, when WHO took stock of this, they realized that the global KMC coverage was less than 5%. And at that point, the evidence was only for KMC initiated in the hospitals, and that was one reason, because we know births happen everywhere, particularly in LMICs. Home births is common. And also, the evidence was only for KMC initiated after the baby is stable. So to address these three issues, to take and make sure that every baby gets Kangaroo Mother Care, WHO started on three major studies. I refer to them as Scale-Up KMC or the SKMC study, the Community KMC study, and the iKMC study. Though I'll be speaking in detail about the iKMC, I just want to briefly talk about the other two studies because it has major implications for us when we talk about implementation and scale-up. Now, this was the first study that I was associated with as a PI, that was how to ensure that we scale up Kangaroo Mother Care, that is the conventional Kangaroo Mother Care after the baby is stable, in an entire population within a period of 2 years. And here our goal was given to us. You have to achieve good quality KMC, that what we call as effective KMC, for at least 8 hours with exclusive breastfeeding in at least 80% of the population in the entire district. Whether the babies were born in the facilities is where we started with. And we wanted to continue KMC even at home. And this happened in 7 sites in India and Africa. And we worked at the pre-facility level. The main focus was on the facilities with the KMC ward and support and training of health personnel. But we also had a strong community component where after discharge, families were supported in giving KMC. And with this paper is published in BMJ Global Health a couple of years ago. And we saw that within a short period of 2 years, from less than 5%, we were able to achieve almost 80% initiation of Kangaroo Mother Care and more than 50% effective Kangaroo Mother Care, that is at least for 8 hours. So this was one study which showed that we are able to scale up KMC rapidly. And we have an implementation model for this, and this is what the countries are now going to be using to scale up kangaroo mother care. The other large trial WHO was involved with was the community-initiated KMC study, which was a randomized controlled trial where babies were initiated into KMC in the community. Either they were home births or they were babies who were discharged in the first 3 days but had not initiated KMC. And it showed that it was feasible to start KMC in the community, and they were able to give long periods of even up to 11 hours during this community initiated KMC. And what was very strong result of this was that community initiated KMC reduced mortality by 30%. And this group of the inclusion criteria were larger babies between 1.5 and 2.25. And this showed that even among the larger babies who are 2 and 2.5 kgs, the reduction in mortality is more than 30%. So this was another big study which has helped change guidelines. And now the guidelines is that kangaroo mother care should be given for all low birth weight babies and not just babies less than 2,000 grams. But the main game changer has been the immediate KMC study, which probably was the most difficult of the three because we were all worried whether it is really safe. I know the KI team was very confident because you all have been practicing this wonderful intervention for, I think, decades now. But in the LMICs, this was the first time that the unstable babies were put in skin-to-skin contact. And this was done in 5 countries, and we had the intervention support by the Karolinska team led by Bjorn Westrup. And the main idea here was, if we are going to wait for stabilization, then we actually miss out on a lot of babies who die in the first few days. And that is why if we start kangaroo mother care early, are we able to reduce mortality further? That was the research question. And this was an individually randomized controlled trial in 5 countries, 4 in Africa and in India. And we recruited mothers and babies with a birth weight between 1 to 1.8 kg. The 2 groups were similar. Both got kangaroo mother care. Both got good quality kangaroo mother care. The only difference was that in the intervention arm, kangaroo mother care was started as soon as possible after birth without waiting for stabilization. And in the control group, kangaroo mother care was started only after baby was stabilizing. There were brief sessions, and continuous KMC happened only once the baby was fully stable. The focus was on continuous skin-to-skin contact, aiming at more than 20 hours per day, and also support for breastfeeding. And all procedures, provision of respiratory support to the baby were all attempted to be done in kangaroo care. And for this to happen, the NICU had to be changed. The mother's cot had to be brought into the NICU, and in 2 of the sites, India and Tanzania, they redesigned a new NICU, and it was called as a mother newborn ICU, where adult cots were put, but again, all the provisions for taking care of a sick baby were available in this NICU. In the other 3 sites, within the same NICU that they had, they brought in one section, they brought in adult cots and managed babies in immediate KMC in these areas. During the NICU stay, when the baby was still unstable, the mean duration of KMC was as high as 17 hours per day. And in the control group, after the baby was stabilized, even in them, the kangaroo mother care duration was around 19 hours per day by the time it was discharged. So it's very important to understand that the difference we see here is only during the phase of the intensive care time, where babies got kangaroo mother care in the intervention arm, but in both the groups, very good quality of KMC happened after the baby stabilized. This study was stopped midway because of benefit, and we had more than 3,000 babies enrolled, where the interim analysis showed that there was benefit, and the DSMB deemed fit that we stop the study because of benefit. The babies that you see who were enrolled in the study were around 1.5 kg, the mean birth weight, and the gestational age of around 32 weeks. The main primary outcome of neonatal mortality, iKMC brought about a 25% reduction in mortality. Mind you, this is over and above the mortality benefits that we see in conventional KMC. In addition, the secondary outcomes of hypothermia and suspected sepsis were also lower. But we did not find a difference in the other secondary outcomes, including we did not find a difference in the median time to clinical stabilization. We did not find any difference in exclusive breastfeeding rates or fully breastfed by hospital discharge. But we were surprised about it, and therefore we did post hoc analysis on additional breastfeeding indicators, and we did find that with the intervention, the initiation of breast milk feeds in the intervention group, infants put to breast before 72 hours, and reaching full breast milk feeds were all better in the intervention group. And it also brought about that iKMC could be an infection prevention tool because there was a sepsis-related mortality reduction. So what does it take for us to practice immediate KMC? We definitely need a policy to permit mother and her surrogates to be in the NICU. Mind you, we did use surrogates. That is, when it was not possible for the mother to do KMC, KMC was allowed by one identified member of the family. We need an MNICU, that is where the mother and the baby can be cared for together, and this is a big change in the way neonatal care is perceived. The MNICU definitely needs all the warmer, the equipment that is needed for a sick baby. But very important is training and monitoring these babies. These babies are sick, they need monitoring, and therefore the healthcare team should be trained to take care of them in kangaroo position, and this was a big role. Here you see Bjorn, and so we have them here who have been doing a lot of work. And other very important aspect is that we need a good collaboration with the obstetric and neonatal teams. This was the other strength that came out of the iKMC study. In fact, even during the proposal stage, it was made mandatory that one of the PI should be an obstetrician. And since the same nurse is now caring for the mother, and very often the mother herself is sick and needs care, we had a minimal care package for the mother too. And we did have to work a lot on conviction of the health workers to change their mindset and take care of both the mother and baby. This study was published in NEJM, here, and this is, in fact, I think it was voted as the most impactful study of that year. And this has now fed into the new WHO KMC recommendations, which came out in November 2022. So what are the big changes in the KMC recommendation by WHO? First of all, from the community KMC study, we now know that KMC is beneficial for all low birth weight infants. So the weight cutoff is no longer 2,000 grams, it's 2,500 grams. Now we are for the first time talking about a minimum duration of kangaroo mother care per day, and that's at least 8 hours if it has to show any benefit. KMC can now be started not only in the facility but at home. And the big change is that from the immediate KMC study, KMC should be started even before stabilization, as soon as possible after birth. And this is a back of the envelope calculations. What is a potential impact of these recommendations? And if you see here, with all the 3 studies and the recommendations that follow from them, it has the potential to save more than 400,000 babies every year. And that means we now have to make sure that we now know what we have to do. We have known for decades, but we now know that even for unstable babies, we can do KMC, but how do we scale it up? And for that to do, WHO, the stage, has convened a KMC working group. Now, stage is the group, which is an advisory group for the WHO to help us focus on what needs to be done. And this stage working group on KMC has partners from all stakeholders coming up, and it's almost out, I would say, on two main things which will help in KMC and iKMC implementation. One is the global position paper, which speaks a lot about Kangaroo mother care, iKMC, and it's a transformative innovation in healthcare. And the second is the implementation strategy on how to scale it up rapidly across the different countries. In addition, the practice guide, which we have seen since 2004, is in revision, and we hope that it is out this year. In addition to that, we know there's always a knowledge implementation gap, and to bridge this gap, we're looking at implementation research, which has started, in 4 countries, 2 in Asia and 2 in Africa. And in this implementation research, we're looking at, in the first phase, a model development on how to scale up iKMC. And this model or implementation model will be tested in a step-wedged manner in 6 cluster districts. And this will tell us, yes, this is the model which will help us scale up Kangaroo mother care rapidly. This implementation research is just beginning, and this will also ensure that at least in 7 districts in each of these countries, we will have strengthening of small and sick newborn care and immediate KMC units, and these all will be centers of excellence subsequently as we scale them up to the entire country and to other countries. WHO is also working towards getting the KMC indicator in ENAP and recording and asking all the countries to report on the proportion of low birth weight babies initiated in KMC. This is the minimum that we are looking at, and the quality of KMC will be the next step forward. So in short, and this is a beautiful picture which I would like to share, graphics. We knew in 2014 that KMC was great, but there was a lot of research gaps, and 3 research priorities were identified, which led us to the scale-up KMC, the community KMC, and the immediate KMC studies. From that, we had the 2022 guidelines, and now we are looking at how to implement it through stage, through implementation research, through dissemination and policy dialogue, and continuing to monitor about KMC coverage. And Kangaroo mother care is truly, I would say, the focus through which we are looking at transformation of newborn care, and the mother newborn in ICU is going to be a total paradigm shift. So thank you very much. And just to highlight that immediate KMC is just right there with the vision and mission of WHO, because you definitely can't get more vulnerable than our preemies. Thank you very much, and I'm open to any questions if there's any time.
Thank you so much, Suman Rao, for this excellent presentation. I don't know how many of you remember that the Lancet wrote in the previous century that oral rehydration was the biggest scientific breakthrough for child survival in that time. And I wonder if this isn't going to be the biggest breakthrough for newborn mortality reduction in this decade. It definitely has the potential to be the most important study, and I know so many of you responsible for this study are actually here. It is very exciting. I must confess I'm not completely unbiased here, but this really has that potential, as Suman said, for transformational change. Before I threw my one question back to you, Suman, I'm just looking around if there's any other question for you. Otherwise, I want to tell you that in 2013, exactly 10 years ago, those of us who were really sold on Kangaroo mother care and its potential for newborn care and newborn survival met in Istanbul. I don't know if Björn or Nils or anyone Ah, we have two who were there. Fantastic. And you remember, we thought then that we had reached consensus for acceleration on kangaroo mother care. We even wrote a piece in in Lancet called Consensus on Acceleration of KMC. And we were maybe naive, but you have to be aspirational. We put a kangaroo mother care target for the global community to reach 50% coverage by 2025. We are nowhere near that coverage. We have some exemptions, and I think Suman Rao in the WHO implementation guidelines and in the position paper, you talk about some of those exemplars that we can look at who actually have reached the furthest in terms of scale up. But there is, as we heard now, a moral imperative to take what we have heard from Silke Madar and now from you, Suman Rao, to scale. It has to happen. And now is our opportunity, and now is our chance with the really exciting scientific basis that's been presented here. Because the thing I think that held us back in 2013 was actually that professionals were still asking questions, as you said, around the immediate care, the safety of that, the do no harm. Could you start early at home? What about the village level? Did you have to have specialist care? There were a lot of those brewing questions. So that hypothesis about immediate kangaroo mother care had to be tested through what has become the standard in research. You do an RCT, and now everything has to go through that. It used to be, if you do a good cost-effectiveness study, that's sufficient. But now you have to do an RCT for things to pass. So, Professor Rao, what do you think now, where we are today? What is the 1-2 things that just have to happen so that those guidelines and that position paper doesn't become something nice on the shelf or something we wave at conferences, but becomes the state of art that you do? What do you think is the final ingredient for transformative structural change?
I think both from the study, the position paper, and even from taking from what Silke said, we have to keep the mother and the babies together all the time. Definitely, we are trying to do it for the stable, normal baby, but we now need to do it for the sickest and the smallest babies too, because probably those are the babies who need them most. So the big change that we need to do is to change the way our NICUs are structured, where mother is only a visitor, sometimes not even that. And we need to make sure that we change it where mother and baby are together. Now, this is not going to be easy. And if we can make KMC reportable across countries through these indicators, I think that will give us an impetus to look at how we can ensure that zero separation happens, immediate KMC happens, and the presence of the mother, even for the other babies who are not small, but they are sick, is going to make a big difference. So that is the change we're looking at.
Thank you, and I'm glad to see that we have a question from someone that maybe joined us virtually or is here a minute ago, and that's a question. First of all, thank you for great talk, Dr. Rao. I was wondering, what do you mean by stabilization? And I think that's very important to explain that, because that was really the thing that's made those caring for newborns worried about how to push this agenda. So please comment a bit of what we mean by stabilization.
Yeah. Previously, babies on respiratory support were not provided KMC. Now, in the immediate KMC study, we had very strict stabilization criteria, which the baby had to meet before continuous KMC in the KMC ward could be initiated. And that meant that they had vital parameters which were normal, that they were not on any oxygen or respiratory support, and they were on full feeds. This was as far as the KMC criteria, it was stabilization criteria in the iKMC. Whereas in various places, people are waiting for the baby to be out of at least mechanical ventilation, CPAP, before they can start on kangaroo mother care. And therefore, stabilization is a word which was used mainly for respiratory support. Even now, when we talk about iKMC, babies who are mechanically ventilated are not, we have not tested in those babies. So we say that, we really do not know. Secondly, babies who are in shock, we do not know. But at least the babies who are on CPAP, respiratory support, oxygen, IV fluids, we should be starting Kangaroo mother care as soon as possible after birth.
Thank you so much. I also want to know, you to know that Silke Mother is still with us, so if anyone has a question for either Sumana or Silke, now is the time to raise those, and I'm checking here if there's anything online. Maybe those of you, maybe you can see, no, I don't think you can see what I can see here on the screen. I see a plate of meatballs and lingonberries and mashed potatoes and time for lunch in front of me. So I was afraid you might be seeing that too and be tempted to reach a closure on this. But I think this has been extremely exciting. And I must tell you, from a global health perspective, this is absolutely one of the most important pieces of work. We have made progress on child survival post-neonatal period, although I'm sure it's sliding backward now because of vaccine coverage, but this is the period, and the closer we get to the birthing moment, as you all know, ultra early, immediate, continuous, that's really the exciting piece of work that now remains. If I would take the liberty of offer one reason I think or one factor that is necessary to take this forward now, it is leadership. Leadership at universities, academia, which I think we heard from our speakers too, but leadership, families, voices. That's how we had a breakthrough in HIV and AIDS, was, those who were involved, the stakeholders themselves, those with the virus who really raised their voices. And what's making a difference in the newborn field is the fact that families and concerned are engaged, are raising their voices. But leadership and government leadership, public health leadership, Folkhälsomyndigheten in Sweden showing leadership here to take evidence to action. So thank you all. A huge thanks, especially now also to you. Suman Rao, thank you for your excellent presentation and exciting work. And we send you also virtual flowers as a thank you from all of us here, and an applause to you and to Silke.